Welcome to Partnerships for Profit, the podcast where we bring you inside the world of joint ventures, strategic partnerships, and powerful collaborations. Each episode, you'll dive into conversations with top entrepreneurs, visionaries, and business leaders, unlocking the secrets to building profitable relationships that drive growth and success. Whether you're looking to expand your network, find new referral partners, or scale your business, you're in the right place. Let's get started.
Welcome to Partnerships for Profit. I'm Dean West, and today's guest is someone who's not only changing how we treat pain, but also how we think about it. We're joined by Dr. Fred DeFrancesch, and a quadruple board certified physician and founder of NeuroMuscular Medical Association with a specialty in physical medicine and rehabilitation, internal medicine, spinal cord injury, and pain medicine. Dr. Fred is redefining chronic pain and care across Louisiana and beyond. But here's the part that really stands out. He's not just treating pain, he's training the next generation to do it better. As a longtime LSU and Tulane professor and the creator of a private 12-month pain fellowship, his impact stretches far beyond the exam room. This conversation will also be very helpful for attorneys, partners, and professionals who care about outcomes and who to refer to for someone who wants to deliver results with back-end science, compassion, and real-world experience. So let's get into it. Dr. Fred.
Hey, how are you today?
I got a list of complaints if we want to go through all of them, but I don't think we have that kind of time. How are you?
Schedule an appointment. We'll get you taken care of.
I know, we'll go that route. So Fred, let's kind of do one. I was going to go through your full list of background and all of your studies that you've done. We didn't have that kind of time either. So let's take it back. What brought you to medicine to begin with?
Well, so when I grew up in rural Louisiana, I loved science, I loved people, and I wanted to do something where I could explore science and interact with people. And for me, medicine was the perfect vehicle for that.
Yeah.
It just fit. And at the time, in a small rural town in Louisiana, the smartest doctor was the internist. I knew there were surgeons. I knew there was a pediatrician, but I didn't even know specialties existed. I just went into it, and through some personal experiences of injuries that I had, I ended up in this field with physical medicine, rehabilitation, and learning more about the spine and injuries, acute and chronic pain, how to prevent things from becoming chronic pain, and those special situations that patients find themselves in when they're in that kind of having those kind of difficulties.
That was going to be my question of what led you to specifically in pain, but it was some personal.
Yeah. So when I was 15, I did a very country boy move. I was driving since I was 10, right? Super normal in the country because the tractor was good. So the car was fine. And then as soon as I got my license, I flipped a car over 2.5 times.
That'll do it.
Yeah. I can't recommend that. I walked away, but had some minor issues with that. And then in medical school, I dove over the front of my bicycle, separated my shoulder, and no one could tell me what was wrong. The internist was like, the x-ray's normal, and it hurt. And I like to think I have a very high pain threshold. Yeah. And the orthopedist said, no, you've got a separated shoulder. He said, what do you do for it? Nothing. Or you can have surgery or nothing. And that just didn't sit well with me. Like, so you can suffer and not have surgery, or you can have surgery and it might work. That kind of brought me into the realm of physical medicine and rehabilitation, where how do I make this better as conservatively as possible without having surgery? And at the time, and I've had my 30-year med school reunion in the last couple months, which is kind of crazy because it doesn't seem that long. But at the time, physical medicine and rehabilitation, which is really the conservative treatment of orthopedic and neurological injuries, was not popular at all.
Why? Why do you think it wasn't?
I think people didn't see the utility of it. It wasn't sexy. It's not dermatology. It's not plastic surgery. It's not orthopedics. You're not fixing bones. You're not doing huge spine surgery.
It wasn't dermatology. It wasn't a pimple, so no one was into it.
No, I mean, so there are things that have some gravitas, like, oh, this. Yeah. And over the years, actually, the field of physical medicine has become one of the most sought after specialties coming out of med school because it has finally been recognized as what it is, and the utility of being able to help patients avoid large surgical interventions through proper treatment. I love it. For me, it's great. And I get to help a ton of people.
Yeah. Yeah. Because it crosses so many boards. So board certified, and why?
Yeah. So
Let me go
when I
there.
first started my journey, I wanted to be I was just a kid from a small country town. I wanted to be the best darn doctor I could be. And so I wanted to be an internist, right? And my experience early in med school with the shoulder, I realized the internists did not know anything about neck and back pain, musculoskeletal medicine. And that's like one of the top reasons people see a physician: neck and back pain. Everyone's going to have back pain at some point in their life, right? And is it something that's surgical? Is something not surgical? It was not satisfying to me to have a patient come to me and not be able to give them an answer.
Mm-hmm.
Oh, you have back pain. Just ignore it and it'll probably go away. Not very satisfying. Like, what's going on? Why does someone's back hurt? What happened? And so that got me into the realm of physical medicine. And then once I boarded in both internal medicine and physical medicine. And then I went on and spinal cord injury medicine. I worked at the VA for a number of years.
That's cool.
Spinal cord injury program because, this is going back into the late 90s, early 2000s, right? They had the Gulf Wars. How was I going to serve my country? It really didn't make sense for me to join the services, but it did make sense for me to give back by working at the Veterans Administration to help the people who had been injured in the service of our country. I mean, that's what I was trained to do. It didn't make sense for me to do anything else. So I did that and started my practice privately at the same time. And that's how that kind of developed. And that's how the multiple board certifications came about.
Right. Well, we're going to come back to mentorship because we talk to a lot of kind of legal people in this world. I'd love to kind of jump into that because you obviously deal with legal a lot. Can you give me kind of the relationship and how that kind of spans for you?
Yeah. So my mentor was a gentleman named Charles Aprill, and he kind of founded some of the societies and some of the spine societies, and he was very well written in the academic literature. He was a radiologist, did a lot of discography work and other work to promote the field of interventional spine medicine, which is primarily what I perform and do now. But there's a lot of medical legal issues with that, right? What is causation? What actually happened? So I find myself doing a lot of forensic type work, and I do it for all sides, plaintiff, defense, whatever it is. The attorneys that seek my opinion usually want to know what's really going on, right?
Yeah.
So I'll call it like I see it. I'm just calling balls and strikes. This person was definitely injured. This person was,
right.
They've got something going on. I don't know that you can relate to the accident. And that information is important so they can, take care of their clients, whether it's the plaintiff, the person who was injured, or the insurance company, if they're defending something that's not accurate. And I do both. I mean, in the last couple months, I've had two very large cases. One was a federal case here in Louisiana, where the insurance company was, they were seeking $1.5 million for a gentleman who was had a slip and fall. And it was, now the gentleman had issues, but it was clearly pre-existing. There was tons of documentation over the previous 10 years before that he had pretty much the exact same issues. So, I mean, the guy definitely had issues. It just very difficult to relate it to the incident in question. So that was favorable for the insurer. And the other case was a case in Kentucky where I was working with the plaintiff, and this woman had a procedure performed improperly, and the physician erroneously injected her spinal cord. That's not good. She was very lucky. I've actually seen two of these cases in the past on the plaintiff side, people who've had neurological damage from a procedure performed improperly. And
it was like a pain med that would normally obviously dull a nerve, but they went into the spinal cord instead of.
Oh yeah. Nothing's supposed to be injected in the spinal cord. That's not.
Yeah.
That's no bueno.
Because that's brain path, right?
So it can cause a spinal cord injury. It did. She was very lucky. It was a small spinal cord injury. She was not severely sedated, so she was able to report that there was something terribly wrong immediately. So like a half a cc maybe went into her cord. And it was in an area of her cord where it did not affect her motor as much as it could have. lots of pain, lots of sensation issues, some bowel and bladder issues. Not great for her, but could have been much more catastrophic. And they settled that case at the 11th hour. I was supposed to fly to Kentucky on a Sunday to testify, and late Friday they settled it because they're experts from some very well-known Northeast Ivy League places.
Called it.
Probably looked at the stuff and said that, realized they were going to have a hard time defending what the facts were, and it was very clear what the facts were. So again, whatever it is, plaintiff or defense, I'm going to call it the way it is. So if the attorney wants to work with me, I'm happy to do so. But it's, I will explain what's going on. If I tell stories, it is not a work of fiction, right? It's nonfiction. My stories are nonfiction. Yeah. Some stories are fiction.
Yeah, so you kind of have to live in that world.
Yeah, I'm a nonfiction guy.
Well, because at the end of the day, you have to get on that stand when it comes to you talking about what you're talking about.
Correct. And I'm very consistent. I mean, it's, you may not hear what you want to hear, but you're going to hear what I honestly think it is. And I'll give you reasons and references and research on why that is.
Yeah.
As opposed to, here's my opinion just cause.
Right.
And that's not really, that's a much harder position to defend.
What do you say some red flags that legal can kind of look for deciding, if this is a chiropractic or kind of a, basic PT thing versus, here's some serious things we need to pay attention to.
Yeah. It's not always as easy as you might think.
Right. There's not here's the 3.
No. And so I had a patient just the other day for a second opinion, and I called the attorney and said, look, I'll do this report. This guy has something real. He's really hurt. And I think they're missing it. Like the treating physicians, I think, are missing part of it. And that happens too. Like they're barking up the wrong tree.
Sure.
And that happens in all cases. I mean, I saw it, a commercial insurance. I mean, again, say Blue Cross, Aetna, without saying any specific names,
sure.
A new patient that came in today who had something that's called CPRS. And it's chronic regional pain syndrome. It causes a lot of dysesthesias and severe pain. And it wasn't treated right. So what this patient needs is a sympathetic block to block the nerves that cause that hypersensitivity. And if it lasts a long time, great. But if it doesn't, then she would be a candidate for a spinal cord stimulator. And she's seen other people, and that hasn't happened. So it happens regardless of what the situation is. In the medical legal field, it gets a little hairier because you will get deposed. You will have to potentially work on the stance. You have to document in such a way that you will get asked questions from a legal standpoint versus a commercial insurer who's asking pertinent questions, but it's a little different. Like, have you done this? Have you met these guidelines? Have you done this? Yes. And this is why. Whereas on the medical legal side, what's the causation? What's the treatment? It's just you're treating the patient the same, but what you are reporting, the physical exam, the treatment's the same, but why, and explaining why you're doing it is different in each scenario. And I think that gets missed a lot in the medical legal field.
Would you say that tends to come down to obviously that, a certain handful of doctors, if you are trained in a certain way, and this is kind of where your brain tends to go, there's more than likely where you end with you assume these are the results most of the time versus thinking outside the box where, your mind has gone in so many different places around the spine and all the things that are going on that you're like, oh, this is leading me this way. And there's a lot of synapses firing versus it's usually this.
So that's true in a lot of different scenarios, right? Some people have kind of like your menu and we're getting a cheeseburger and fries and a soft drink. Would you like a shake? That's kind of the most they can mix it up, right? Yeah. And they have a set menu, and you're getting this first, and then this second, and this third, and they're throwing stuff, and eventually something catches or doesn't. I don't know what to do with it. Now I'm going to send you somewhere else. Versus really investigating what's going on, and if you do it long enough, you could, with a few questions, you can really fish out what's really going on and help these patients in tremendous ways. Yeah, and it's very satisfying, especially when, many physicians are in scenarios and situations where they are limited by their institution, right? They have to go through a certain set. Like their institution demands it. Like, we want you to do this first, and then this first. Sure. And they will get either rewarded or reprimanded if they don't follow the script.
Yeah.
And if it works for the patient, it's great. The problem is when it doesn't work for the patient, they kind of fall through the cracks and get lost.
Yeah. What would you say would be like a normal mistake that you find in cases where the legal is stemming the client a certain direction when it may not necessarily be the thing that they need to be aiming at? You know what I mean?
Oh, there's not one. I think what happens is physicians who are treating medical legal cases generally will have blinders on and they go through their set motion.
Mm-hmm.
And it may help a lot of times, but it also makes it possible to miss something that's right in front of them, right? Like, oh, we're focusing on the joints, Well, this is a disc. And no one's done that. What I see a lot is there's, for some reason in the last, I could talk about this you can do a podcast for an hour on this one topic.
We'll come back. We'll have to bring you back.
Yeah. There's a procedure called discography where you literally put a needle in the disc and you test it. And there's a right way to test it. There's a wrong way to test it. And it can tell you if that disc itself is hurting. Does this disc hurt? How torn is it? Is it something that's causing pain? A pain generator, right?
Yeah.
What is generating the pain? If you can identify what it is, then you have options to treat it. And I think what happens is a lot of times, again, the blinders are on, and some of the physicians and other providers will miss something that's right in front of them. And like, well, we want to treat the joints. We want to treat this.
Yeah.
And there's something else going on. Or you have a herniated disc that looks bad, but it doesn't hurt. But it's the disc next to it. So if you don't do the discography and do a surgery, now you have a surgery that's in a patient that is fixed, quote unquote, but they're not better because the pain generator was not identified prior to the surgery. I see that a lot, and that can help a ton of patients, not just medical legal, all patients.
In general, yeah.
Yeah, what's actually going on? Well, I know because it looks bad. If anyone who's owned a used car ever knows, just because it looks bad doesn't mean, one of the best cars I ever owned was not the prettiest thing in the world, but that was just bulletproof. And sometimes, and I had a great looking car that was a disaster, right?
That happens.
Yeah. Right. And so you got to kick the tires. And that's kind of what discography is. You're kicking the tires. You're looking at each individual disc saying, this hurts, this is torn, but it doesn't hurt. This is torn, but it hurts. It gives you more information. And you would want that before going into a large surgery.
Sure. Or anything that's going to numb out the pain that might be telling you that, here's the trigger point. Here's where our problem's at.
Right. It's better to know than not know.
Absolutely.
And it's better to know before than after.
Yeah. All right. I'm going to give the legal side a break for a second. Let's come back to the mentorship. So you started the fellowship, right? 12 years ago or no?
Well, so there's this current
developed.
Yeah. So it kind of developed over time. So it started, I was training fellows that were going through the Veterans Administration back in the early 2000s.
Okay.
And it wasn't even a pain fellowship then. They would call it a musculoskeletal fellowship, right? It didn't even exist.
Yeah.
In the late 90s, some of these were beginning to get developed. And Charles Aprill, who was a longtime practitioner here in New Orleans, became associated with LSU. And so my relationship with Dr. Aprill started then. I'd spend every Thursday when he was at Charity doing the procedures, learning the procedures, watching. He said I could stay and watch if I kept my mouth shut. So I did. I just absorbed as much as I could.
Yeah.
And then over time, I started doing some procedures with him in his clinic. And then it just developed into a working relationship. I rented some space from him. Like, I need some space one day a week. He's like, I don't use it on Fridays. I'm like, perfect. And then it just developed over the years, more and more. Just it was almost like a mentorship and an apprenticeship. It was really a unique kind of setup. And that guy forgot more medicine than most of us will ever know. He was brilliant.
I was going to ask, how do you feel like that shaped you? But I guess that it was the shaping, right? That was.
Absolutely. Because he was a radiologist by training. And how many radiologists has anyone ever seen that does a physical examination? Right. And he could do a physical examination better than a lot of just your average physician. So he learned it because he knew it was important. And I learned how to read MRIs of the spine from Dr. Aprill. And that's, he was a brilliant mind, and he helped a lot of people. He wasn't always very popular because, again, If you're willing to call it like you see it, you will not always be popular.
Yeah.
But that's okay. So that was just an amazing, and it completely accidental. Right? Had I not been from Louisiana and ended up in New Orleans and did my training in New Orleans, because it's the only place that had the combined program that we talked about, where I did internal medicine and physical medicine both.
Yeah.
They only had 5 places in the country that did that. And New Orleans was one of them. And I decided to stay. Worked and trained at Old Charity, which was tremendous experience, and then got to work with one of the best people in the world. When I met him, the first time Dr. Aprill gave us a lecture in 1996, 97, he talked about cervical facet joints and referral pain patterns. And I thought everyone knew this. And here we are 30 years later, and everyone is just now starting to appreciate and understand that. And I just took it for granted that that's the way it was done everywhere. And it was not. So it kind of it's interesting to see how long that arc is for things to be accepted.
Okay, I'm gonna come back to you give me that track, what ended up being what is now the fellowship, but because you said that, it stemmed me back. For legal, what would you say is some standards to look for when you're trying to find the right medical doctor to work with you for your case?
Oh, so you want someone, you need to be able to communicate with them. If it's, you need to find someone that kind of understands what is involved in a medical legal case, right? And so there are some unique factors to that. Not every physician is going to be comfortable. They may be comfortable treating a patient, but they may not be comfortable giving their opinion and sticking to their guns, because in a deposition, you're going to get pushed a lot of times. Like, why do you feel that way? And you should have enough information, enough knowledge of the medical literature to give the reasons and the references to why you think that way. And this is why it is. And a lot of physicians don't have that, right? They're kind of all hat, no cattle.
Mm-hmm.
They talk a good game, they present well, but when they're, push comes to shove and they're presented with the facts, they fold like a paper towel, right? So you need someone who's
had some years of doing this at least.
Oh, yes. I mean, pretty much what I've seen is almost anyone can do medical legal work for about 3 years, right? Because that's about how long it takes for someone to get in and have to do a deposition. And then the attorney finds out if they can actually do a deposition or not. And then they fold and they're like, what happened? I'm like, well, the guy was all confidence until someone called him on it. And then he ran scurrying. It happens, so confidence is not competence, right? Yeah. And everyone, it's not just physicians, in every field, you can find that mismatch, right? The competence-confidence mismatch.
Yeah.
You're not looking for that. You're looking for someone who has a good match of confidence and competence. And
I would say the one looking for experience, but more than likely, kind of like the cream rises to the top. Like if they've been in this long enough, they're either been booted because they weren't doing a very good job, or they've stuck around long enough because they've been doing a good enough job.
Correct. And so what you'll see in the I'm in the New Orleans area, right? And basically in Southeast Louisiana, you can probably count on I would say one hand, but maybe two hands, the number of people who do interventional pain that have been doing it over 20 years independently, right? Yeah. That's a very rare thing. They're either under the umbrella of a large hospital or university. There are a lot of unique challenges to this field, and it's hard to do it well over time. Now, again, you brought up the fellowship earlier. I started that with Dr. Aprill back in right after Katrina. We taught 3 fellows, and then a 4th fellow was poached by Cleveland Clinic. He called up. He goes, "The Cleveland Clinic wants to offer me a fellowship," and I'm actually still friends with this guy. He's in Arkansas now, and he actually is one of the reasons I got one of my new fellows. I said, "Go to Cleveland Clinic." I mean, people may not know who Dr. Charles Aprill is in 20 years, and they may not know who the hell I am in 20 years. But everyone knows the Cleveland Clinic. Go to the Cleveland Clinic. That has some, that's kind of impressive. Go and learn what you need to outside of that. It's not a big deal.
Yeah.
So we did that, and then, Charles, they had COVID, and Charles passed. There were a lot of, things going on in the world the last 10 years. So there was no more fellowship, and we brought it back a few years ago. And we have, today is actually the first day of our third fellow in the new fellowship. Yeah. And so it's NASS accredited, which is North American Spine Society. So it's basically well respected.
That's awesome.
Yeah. And it's, they get 12 months of time. They learn how to do the procedures based on how well they proceed in advance. We have some ballistic dummies, which is basically a fake patient. So they're not practicing on real patients. They practice on and when they get good with that, then, they can discuss it with the patients if they're going to move forward at that point. They need to be competent before they actually touch real people.
Yeah, and we all appreciate that.
Yeah, I think it's a great setup. I mean, we've had the first guy, his name was Will Lee. His hands were really good. So I'm proud of all the fellows that came through. There's 3 of them that are working here in Southeast Louisiana now, and they have good hands. And I think they got good training. And no matter what, you can't learn it in 12 months. It's
sure.
Yeah, it's the beginning of their
learning,
training.
Constant.
Yeah, lifelong learning. I mean, you're always learning new things. Yeah. So,
all right. Before we wrap up, because we're getting close to the end here, I got a few more questions. Let's see what I can give some fiery questions for, so we don't get. Well, actually, let me jump on this. This is a pretty good one overall. Where we're at in this lawyer side of stuff. What would you say is the most misunderstood treatment of intervention that you offer?
Oh, well, there's, I think discography is misunderstood, right?
Okay.
Yeah. And so there were a couple components to that, because there were some articles in the late 90s that kind of poo-pooed discography, like this is dangerous, and it's not. Right. The studies clearly show, and I was responsible for one of the papers noting all the issues with those studies, saying they did it wrong. And if you do it wrong, you're going to cause problems.
Sure.
Right. And so what happened was this surgeon at a large academic institution on the West Coast, which will remain unnamed, did this study and said, this causes damage. And it doesn't, because there's been subsequent studies that have shown if you do it by the guidelines, you don't cause damage. But if you do it wrong, you can cause damage. And so a generation of surgeons thinks discography causes damage to the discs, and we don't need to know what it shows. We're just going to do surgery. And what happens down line is, now I'm doing surgery. You may get better. You may not. I don't really know what's going on. And so now you have a chronic pain epidemic. You could think even into the medications and the Sacklers and the OxyContin thing, all the years and pain, all these, there is literally a syndrome called failed back surgery syndrome. It's a diagnosis, right? You don't want that. If you're going to have surgery, you want to be better, right? And discography should be able to and can give you a guideline of where you go. On top of that, it's also misunderstood. Yeah. There are things you can inject into the disc. So people used to inject steroid, and it became very controversial. And there was a paper recently from a colleague of mine, Dr. Skeepers in the Netherlands, who says, you can inject steroid and some of those patients get better. So if they get better, you don't need to do surgery. Right. And then there are some other things. There are orthobiologics. There's something called, I won't go into trade names, but there are orthobiologics. There's artificial disc material. There's ozone. There's minimally invasive nucleoplastics and other things that can be performed before a large surgery that can really provide a lot of relief. And I think the disc is misunderstood. I think discography is misunderstood. And the saying in the parlance of interventional spine is the disc is where good therapies go to die, because I think it gets lumped into one big garbage bag and it works in some and doesn't in others. And then it's just disregarded. So I think the disc is the future. I think everyone thinks that. Just still at this point, no one knows what to do with it.
Yeah. I feel like it's kind of like across the board in medical right now, because everything is moving so quickly with our knowledge, our studies, and our tests that if you're not keeping up, there's a large portion of the medical information that you could be using that you just haven't had time to even look at.
Well, so
it's so fast.
That it's an interesting point, because what's happening is you're getting the volume and the number of scientific papers that are being published is at an all-time high.
Yeah.
The question is, what is the quality of these papers, right? And we've seen in society, the science, everyone likes the idea of science, but not everyone appreciates what science actually is.
Mm-hmm.
And look, I review for several peer-reviewed journals. I look at articles and see if they're valid to submit. And I have rejected articles in certain journals for publication based on problems that I identified, and I've seen them published in other journals.
Yeah.
Right. So they'll just pull it and put it in another journal, and maybe it passes peer review. If you don't have the data right, if you have if you can't prove that you're actually doing so, I mean, I've looked at papers on interventional procedures. I'm like, send me at least one picture of what you did. I'm not saying you can't do it. What you're describing doesn't seem possible.
Yeah.
To me. Maybe I just don't know.
Sure.
And I've had papers like that withdrawn because they don't want to submit a picture. Right. So show your work. It's like 5th grade math.
Yeah. I feel like that's fair.
Show your work. It's just show me one.
Yeah.
And I'll believe it. Right. And I've seen published articles where they show a picture that doesn't represent what they say they're doing.
Yeah.
Unless you don't know. So even though we have more scientific papers, as someone who's written scientific papers, to do one well is very challenging. It takes forever. It's easy to write one that's not done well.
Right.
But it's important to get it right. And you have to be careful with what the science is saying, because you have to do a deep dive into the data sometimes and really fish out what's going on. Sometimes some of the conclusions, everything will be right and the conclusion is wrong. How did you draw that conclusion with the data at hand? Right. And I've asked that and they're like, oh, that's a great point. Okay.
Thought that would have been a first.
I thought that was obvious, but I guess it's just fascinating and it's really collaborative. But even though there's more information than ever, it's like the internet. There's so much stuff on the internet. How do you find what is pertinent and valuable? Right.
All right. I'm going to give you a couple quickies, and some of these are fast answers. I'll try to stay on my fast answer ones. Here's a fun one though. If your 4 certifications were superheroes, which one would be the strongest?
Oh, that's a good question. The quietly strongest. Oh, I would say physical medicine.
Okay.
Yeah, but it'd be the quiet strongest.
All right. If you couldn't use any traditional diagnostic tools, only your gut and a conversation, what would you ask a patient first?
Oh. What makes it worse?
Okay, that's fair. And then I'll jump up to the top for super fast ones. Coffee or tea?
Before noon coffee, afternoon tea.
Okay. Favorite medical school memory, I guess. Give me a favorite medical memory. Give me a short one.
No, that's my favorite medical memory. I can't.
Oh, yeah. Rated dog. Moving on.
Yeah. Sorry.
I think we covered that one. Go-to leadership advice.
Oh, do the right thing.
There you go.
Yeah, do the right thing. If you're always doing the right thing, do the right thing. Super simple.
All right. And then last one, your personal reset ritual after a hard, rough day.
Depends on how long the day is. Right. Yeah. Hot shower.
Yeah.
Usually my rituals in the morning, like I try to get a run in. Today was kind of exercise in the morning is key. Right. And a long hot shower and going to bed at the right time is perfect. If it's really tough, sauna, like infrared sauna for 20, 30 minutes is great. A stretch. And I pray before bed every night, just about. That's helpful. Kind of gets my mind at ease, whether it's meditation. It's good for me.
It's connection. Yeah.
Yeah.
Well, Doc, thanks for hanging out with me today.
Thank you. This is actually, of course, very enjoyable. But
good.
Hopefully,
I've heard you enjoy talking about yourself. I'm kidding.
Everyone does, man. That's human nature. Can't help themselves.
No, it was a really fun conversation. So thank you for hanging out. And like I said, maybe we have to bring you back and we'll dive into some other ones. This might be a fun little section of the podcast we can talk about what they're dealing with on legal sides.
I'd be totally down with that. Thank you very much. Appreciate it.
All right. Everybody, we'll see you guys on the next one. Oh, wait, Dr. Fred, fastest way for people to find you.
Oh, wow. Well, you could call 1-877-4-Dr. That actually gets you to the office. But nmaclinic.com. N as in Nancy, M as in Mary, A as in Alice for NeuroMuscular Medical Associates. nmaclinic.com or 504-469-4691. That works too.
And how late is your call line open?
Oh, it's until the wee hours. There's voice message. We don't do the fancy AI.
We're going to sign off before this goes. Thank you guys so much. We'll see you on the next one.
Thanks for joining us on this episode of Partnerships for Profit. We hope you've gained valuable insights on how to form profitable partnerships and take your business to the next level. Be sure to subscribe and leave us a review wherever you listen to podcasts so you never miss an episode. Got a partnership story to share or someone you'd like to see featured on the show? Reach out to us. Until next time, keep building those partnerships for profit.